He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Welcome, folks. This is the Stay Off My Operating Table podcast with Dr. Philip Ovadia. We're glad you joined us. We've got a little bit of different one here today. We've got two guys talking with a gynecologist. I have absolutely no idea how this is going to work out, but we were having a little bit of conversation prior to starting the recording, and it might not be as wildly uncomfortable as it feels like it's going to be. Phil, introduce our guest.
Yeah, definitely excited to have Dr. Andrea Salcedo with us today. Andrea is known as the Conscious Gynecologist, and maybe we'll ask her if that means that all the other ones are unconscious. Don't know, but they may be. But I was fortunate to finally meet Andrea in person at a conference. I guess it's a few months ago now as we're recording this. And she gave an amazing talk there, and just knew we had to have her on the podcast to talk about, again, might not be intuitive how gynecology and metabolic health overlap, but we'll get into how there is certainly a big overlap there. So, Andrea, maybe you can give a little bit of your background to our audience and talk about how you got involved, how you got interested in gynecology, and then maybe what got you interested in metabolic health.
Yeah, hi, thanks guys for having me on. I'm really excited to be here. I'm a big fan. And so, yeah, I'm an OBGYN. I'm an academic OBGYN, which means that I work at Loma Linda University School of Medicine. I teach the next generation of medical students and residents, doctors, about how to become OBGYN. I also am a clinical researcher. I have a couple of ongoing studies and something that's going to be published in a couple months as well. And I have a telehealth practice, and I have gotten into this space because, gosh, I was probably, trying to have my second child, and I was a complete metabolic mess. Like, I didn't appear that way, but I was pretty thin. I was about 120 pounds and had regular periods, but I was following a very plant kind of based diet in a way. I was eating quinoa and chicken without the skin. And I was having a really hard time getting pregnant. I was at a really stressful job. I was working for a big HMO in California. I think a lot of people know where that is. And I was really unhappy, and I was making a lot of money, but I was really unhappy and I couldn't get pregnant. And so I quit my job, and that probably brought my insulin levels down like a ton. And I went back into academia, and I got pregnant within 2 months. And after that, I carried my son, but I had gestational diabetes, and I had a 1 hour glucose test of 200. And everybody was surprised. They looked at me like, how is it that you had a 1 hour glucose test of 200? You're 124 pounds at 24 weeks pregnant. And, but yeah, I mean, I was like, kind of like the diet that I was eating, telling you guys, that for that whole time, low fat things and just lots of vegetables and grains. And I felt kind of sleepy and exhausted. And yeah, they didn't even put me into the gestational diabetes classes because they're like, oh, you're so healthy, you don't need any of that, but when I started checking my blood sugar, I couldn't get my blood sugars under control. And I probably was in ketosis at the end of my pregnancy. I could actually smell like the cherry breath that I had, because I could not have one bit of carbs. I remember one time it was during like Mother's Day. And on Mother's Day, I just wanted like a pancake. Like, I just wanted a sliver of a pancake for Mother's Day. So I had a little pancake, and it was like this big, it was like 2 inches, and my sugar went to 175. And so it was just, I was so insulin resistant. And that happens with pregnancy anyway, but I was already coming in with these really bad risk factors. I was like the slender, like PCOS kind of person, like probably like the person that is the toe feed, thin on the outside, fat on the inside. And once I went down super low carb and almost ketotic, probably, my blood sugars were under ketotic. So like in ketosis, right? And I was eating no carbs. I was probably burning all these ketones. And my son came on time. He was 6.5 pounds. It was like a super easy pregnancy. But then I started realizing that, like, why is like the standard of care telling me to eat at least 30 grams of carbs per my meal, 30 to 50 grams with like very low fat when I was pregnant? And that was throwing my numbers all over the place. I probably would have needed insulin had I not just done this on my own. Then so I started getting into the nutrition network and I started taking a lot of their courses and realizing, hey, wait a minute, like high insulin levels, body inflammation, if it affects the heart and like the liver and the kidneys, in what we call end organ damage, body inflammation that attacks like the end organs. Why is it that we're not thinking about the uterus and the ovaries as end organs and recipients of inflammation, just like any other organ? And in fact, the pathology studies from the 1960s reveal that the same cells, the same muscle cells, inflammatory, what we call progenitor myocytes, that cause hardening of the arteries, atherosclerotic disease, are the same ones that cause uterine fibroids, which is like a big problem in gynecology for a big source of abnormal uterine bleeding.
So this is really cool. The same thing that causes atherosclerosis, Phil warned you, I'm not medical.
Yeah.
The same root cause of uterine fibroids.
Amazing.
That seems big.
It's super big. And we've known this since the 60s. Okay. The problem is that we're so good at surgery and medicines that, and rightly so, some people need this intervention because they're bleeding from heavy periods and things, and, and they need blood transfusions. But like we've forgotten to teach our residents about how the uterus like develops pathology, and we don't connect it to like real world understanding of the view of gynecologic disease and connecting it with cardiovascular disease. So when I teach them, and a lot of the talks that I give are gynecologic disease is actually cardiovascular disease, right? Like the uterus is actually one big smooth muscle that comes from the same blood vessels that line every single blood vessel in our system. So when I put that together, it was like, oh man, there's something here, and there's like a whole field of research that can be opened up. And that's a big part of what I do.
It's interesting because what you just described to me is an epiphany that you as a practicing doctor had, which I have had as an uneducated, at least scientifically uneducated person, which is that the individual systems of the body are not discrete. They're all part of one system. They're subsystems, but they're all part of the same thing. And something that affects one is likely to affect the other. It struck me, I felt for a long time that modern medicine has gotten so deeply siloed that there's now what 26 different kinds of cancers that all have their same specialist. For if you've got cancer in this particular, in the left side of the back of your prostate, you've got one kind of doctor, and if it's the left side of the on the front, it's a different kind of doctor. And it just never made sense to me. What you're saying, that makes sense. That really makes sense. Okay, sorry. Let's dive deeper.
Yeah, maybe talk about how big an issue this is. And maybe we'll just start with gestational diabetes. How common is that? And why is it a problem? Because, many people think, okay, while you're pregnant, you have this, but then it goes away afterwards and, not that big a deal. Talk about maybe why that isn't the case and why gestational diabetes is a big warning sign.
Yeah. So we have to remember that insulin resistance in pregnancy is normal. Okay. Like there are a few different phases of a woman's life where insulin resistance is normal. This is one of them. Okay. The reason why we have insulin resistance in pregnancy is because we need the extra glucose to get sent to the baby because there's so much energy processes happening. That's normal. Plus, it also is needed during breastfeeding. Okay. But we live in such a society where carbohydrates are so plentiful. Okay. There's so many of them and they're just all over the place. And people have just this access, and our glucose levels goes way higher than nature really intended. And then it's a problem because it makes it really difficult for women to have vaginal deliveries because their babies are so huge. It makes it difficult because of weight gain, and they become more difficult and complicated surgical patients. There's even concerns that could be one of the root causes of like autism with brain inflammation due to high glucose levels. There's all kinds of worries about the inflammation that comes with high insulin and high glucose. And so it's just that modern culture has taken it like to the nth degree of the amount of concentration of glucose. Then when you have gestational diabetes, and it's the placenta that causes this hormone that makes it more difficult for glucose to latch onto insulin. And so then when the placenta is delivered and you have the baby, okay, then this goes away. However, most women that have had this gestational diabetes that is either insulin or diet controlled, it's a predictor, an independent risk factor for diabetes in the future. In fact, like me, I'm a Mexican American woman who my risk factor, the data says that in 10 years, I have a 50% chance of having type 2 diabetes after having my child from gestational diabetes alone. Okay. That's huge. And so when I realized that number and saw all the studies that indicate that, I was like, there is no way that I'm getting diabetes. Like, I am a doctor. There is no way that this is going to happen to me. If anyone else, like, we should not be getting this. And so that's why I also did like these deep dives of what's really normal, what's not normal. So gestational diabetes is an independent risk factor for diabetes and cardiovascular disease and metabolic dysregulation in the future. So women really should be careful and have that understanding that it's not just you had a big baby or they didn't catch it or whatever. It still means that something was not right and your body was showing us by all of these signs that we have.
And I just want to kind of reiterate something that you said, insulin resistance, which, we talk about as a problematic state for the most part, is normal in pregnancy. And again, the reason is that if you kind of think ancestrally, and glucose, which was maybe a little bit of limited resource, right? Carbohydrates were limited. The mother's body is prioritizing that glucose going to the baby to help the baby develop. And unfortunately, in our modern environment where we're, overloaded with carbohydrates and sugar, this now causes extra problems in the mom's body because the mom has become basically resistant to insulin. And now we keep pouring in all of this glucose and carbohydrates.
That's right. That's exactly right. And I like that you brought it to kind of what ancestrally what the normal life was, because I love thinking about medical anthropology and what was the biologic function and adaptation for this. And the interesting thing, and this is kind of fun if you guys are parents or know people who've had nausea, vomiting in pregnancy, the first trimester, there's like really interesting adaptation where women are not hungry, they're throwing up, or everything brings them nausea, right? Here's the reason why. The reason why is because the baby doesn't have a pancreas yet. Okay. So in the first trimester, there is not a pancreas that's functioning that secretes insulin so that the baby can keep normal glucose levels. Okay. So it actually relies on mom's aversion to food to keep glucose levels nice and steady. And that actually promotes ketone production at the placenta to help with brain development. I'm looking at your face, Jack.
This is so cool.
In essence, the preferred state for the developing fetus is a ketogenic state.
First trimester, yes. Second and third, it changes a little bit, but In the first trimester, absolutely. And so that aversion absolutely has to do with that. And then the other thing, this is really cool too. This is kind of weird stuff, but you guys know a lot of folks who are carnivore, right? And in the first trimester, a lot of women are like carnivore and they get pregnant and they're on carnivore and they're really excited, but then they have this aversion to want to eat meat. What's that about, right? When did we get the refrigerator? Okay, we got the refrigerator like 70 years ago, right? And so the biggest source of food poisoning back then when we were cavemen was spoiled meat. And so our body over thousands of years has learned to avoid meat in the first trimester so women don't get food poisoning, which is like a really, protective time because the fetus is developing, all the organs are developing. The other thing is when we were cavemen and we would sacrifice an animal and we would eat nose to tail. And so we would eat like all of the parts, but how would we eat it? We would roast it over an open flame. And so when you eat meat that has been roasted over an open flame, there's like char pieces on it. And like, when do you not want to introduce carcinogenic material to someone's body when there is a fetus that's rapidly growing and the DNA is replicating? You don't want to introduce potentially carcinogenic material at that time. And so a lot of women have this crazy aversion to anything roasted or meat, particularly coffee. It's like really funny because they're like, I don't want to drink coffee anymore. It's because of the roasting process. And so it gets better after the first trimester, but like the aversion to food and meat particularly, it's really interesting, but it has a biologic adaptation. So I always tell women, if you don't want to eat, don't, because your body actually prefers to be in that low glucose state. And you just have your electrolytes, so drink salted lemon water because it has sodium, chloride, and potassium, which is really what your body needs. And it helps a ton. So it's fun. It's fun to teach people those biologic adaptations. So thanks for bringing that up, Phil.
Yeah, very interesting stuff. One of the other adaptations I find fascinating is I know many women, my wife included, who, when they got pregnant, they went from, eating meat, maybe on the rare to medium rare side. They can only eat it well done, and probably again ties back to the same, avoidance of perhaps undercooked meat that could be problematic. Very interesting. You mentioned earlier also, while we were talking about the pregnancy issue, you mentioned PCOS. Maybe we should go a little bit into what that is and why that is another, harbinger of metabolic disease.
Yeah, so PCOS is something called polycystic ovarian syndrome. And so it's a syndrome. It basically refers to a problem that comes and goes depending on what's going on in your life. And so it's most commonly found in like reproductive age women. And it has to do with two things. It has to do with high insulin levels, and it also has to do with inflammation. And so when we have these two factors, it starts to cause problems and changes a woman's ability to ovulate, which is, ovulation, and then be able to have their menstrual cycle every month. 10% of women out there have PCOS, okay? And you have to have irregular periods to meet the diagnosis, hair where you don't want it, or like extra acne, which is basically signs of androgens or testosterone, and tiny small cysts on the ovaries that don't actually need surgery to be removed. Okay, so you have to have two of the three. A lot of these big organizations like kind of argue about what really is the diagnosis, and can you just have hirsuti or hair where you don't want it, or can you just have irregular periods, or the function of the other? And it really just depends on where you are in your cycle in your life. Well, a lot of women know this inherently, that whenever they go through a very stressful time in their life, they'll miss a period, okay? And that has to do, for example, like if there's a death in the family, or they're going through, I don't know, college women are going through finals or something, and something really stressful happens, they skip a period. And a lot of women are like, oh yeah, I know what that is. Like I was super stressed out and missed my period. The reason why is because that stress, that metabolic stress, causes high insulin levels, and then the high insulin levels affects the ovaries, and that causes higher testosterone levels. Then that high testosterone level affects the liver and changes one of the concentrations of a special protein that gloms onto those extra hormones circulating. And so because there's less of that, then there's more free circulating testosterone and estrogen. What happens from there is it actually blocks the the high levels of estrogen and testosterone blocks the signaling in your brain, your hypothalamus, from sending signals to your pituitary gland and your ovary to ovulate. And so because of the high insulin level, it actually sends signals by several steps to your brain to stop ovulating because you're under some sort of stress. And that stress could be all kinds of different things, right? It could be, social stressors or lifestyle stressors. It could be food stressors. And so going back to the anthropology of this is like when we were cavemen, what happened in the harvest time? We would eat lots of fruits and vegetables in order to gain weight and have high insulin levels because the fast was coming during the winter time, right? And so when the fast comes in the wintertime, there's not enough food and that kind of stuff. And actually sometimes can cause the reverse effect of and prevent ovulation too. And so remember that time of where there was fruits and vegetables was very short. It was only like 1 or 2 months, right? And so our body was made to handle and adapt to that high insulin level during that time. But the other 10 months now in modern day, we have just so much of this food and lifestyle stressors that it keeps our insulin level chronically elevated. And if you think about the biologic requirement for women to have baby, like how much resource it takes for her. So it's 1 year being pregnant and 2 years of like crazy active child rearing, breastfeeding, and like just really with the child. That's a huge biologic investment for women. So when your body senses that it's under a stressor, it won't even let you think about it. Your irrational brain is, oh yeah, I can totally have a baby. Let's have a baby when we're like under really big bad stress or metabolically unhealthy, right? But our reptilian brain, like our old brain, is constantly sensing what's going on, and it's very much triggered by insulin. And so insulin is a stress hormone, as we all know. And so if there's too much of it, it's actually going to block ovulation to prevent women from having a baby at a time that's not right. And so that's PCOS, okay? Which the little ovaries are actually, the little cysts on the ovaries are actually like the body trying to ovulate, but it didn't get the right signal because of the lack of because of the metabolic dysregulation. I can see your face again, Jack.
Am I crazy? Am I crazy, or is this really wildly insightful stuff that is not commonly understood, Phil? What? I mean, granted,
Yeah.
I've never had a gynecologist, but I've been around women a lot, and oh my God.
Yeah, no, I mean, so we've kind of hit on two of these gynecologic issues, right? That are early indicators of, insulin resistance. And it's a huge missed opportunity. And one of the things I'd like to maybe have Andrea touch upon now is, and this goes back to your story, right? You were practicing gynecologist, you get diagnosed with gestational diabetes. Low carb is not a standard recommendation. I mean, and as far as I know, for 99 out of 100 gynecologists, probably it's not going to get mentioned at all. So what led you to low carb, and what do you think is kind of keeping your colleagues from, recognizing what a useful tool low carb might be, and the broader picture of, kind of missing the insulin resistance that's underpinning these conditions?
Yeah, it's really important because our clinical guidelines, right, of treating polycystic ovarian syndrome says that the first line approach to treating PCOS is lifestyle, okay? The problem is that nobody knows what that means, okay? And for the last 40, 50 years, we've been giving and promoting the low carb or the low fat lifestyle. And so if you don't eat fat, then already your body doesn't have the building block to make cholesterol to create all the hormones that your body needs to actually ovulate. So that's another story. But so we haven't been promoting that, but it's really nice because in my practice, I just teach them exactly what I taught you. And then the light bulbs go on, and that's okay. I have to reduce my carbohydrates and I have to reduce my stress. Okay. And then I give them 3 months. I'm like, I'll come back in 3 months. And if your period returns back to normal, we're good. But the thing is that doctors are worried about women not ovulating, okay? Because after many years of not ovulating, it increases a woman's risk for uterine cancer, okay? So that's why, because lifestyle changes didn't make sense or we were promoting the wrong ideology for a long time, everybody knew it didn't work. And so then what happened? They gave patients birth control pills or metformin, right? And all of those things, birth control pills, number one, just kind of mask the problem. It increases the amount of something called sex hormone binding globulin, which decreases the estrogen and testosterone levels so that you don't get hair anymore where you don't want it. And it kind of just shows that you have a period by the withdrawal bleed of the pills, but it doesn't fix the root of the problem. Metformin is sort of helpful because it helps your body use insulin a little better, but it still doesn't get to the root of the problem either. And so you have to talk about insulin resistance. You have to talk about hyperinsulinemia in this conversation because PCOS is like pre-diabetes. It's like the first phase of pre-diabetes that we see in women. And so it's not like a reproductive disorder necessarily. I mean, it impacts reproductive health, but it really is a metabolic disorder. It's really most women who have PCOS fit and meet the criteria for metabolic syndrome in like their teens, in their, early 20s and 30s, and so it's such a huge missed opportunity to talk about, impending cardiovascular disease that can happen to women. And it's not like fertility, it's like a really big deal. In fact, a couple of years ago, I did a talk for Low Carb USA and I termed it, it's not just PCOS, because we tend to silo women in these, oh, it's your period or your hormones or whatever, and that's just the manifestation of how our metabolic dysregulation is, but it's not because we're women, it's just how we show metabolic dysregulation rather than maybe a man would, and so it's very interesting. I think there's a huge missed opportunity here, and that's why I feel so passionate about this subject.
Yes. Oh my God. My mind's blown. I mean, I've always put women problems off in this category in my mind of things I don't want to think about because there's nothing I can do to help anyway. And you're pulling it all back together to metabolic health. And you can watch the lights coming on for me here. I'm realizing it's just like everything else, it's all tied together. I wanted to ask you about something that you said, I don't know, 15, 20 minutes ago about when women in that first trimester are nauseous and throwing up all the time. And it's because the developing fetus doesn't have a pancreas. And so that's the body's response to protect the developing fetus from too much glucose in the blood. I'm not exactly
That's
sure.
right. That's right.
So
Yeah.
what happens? Do we have any insight into what happens with the anti-nausea drugs when women are given anti-nausea drugs so that they're not throwing up, so that they can eat? I mean, it seems to me like that's just another example of putting a Band-Aid on a bleeding artery, or maybe worse, solving a problem that isn't really the problem.
Yeah, a lot of my patients that do put them on these medications like on ondansetron and all these anti-nausea medicines, they feel terrible. The mood goes down because it affects so much serotonin receptors in their brain and in their gut and stuff. They feel really depressed and down. I mean, I don't know what comes first, right? Because when you're nauseated all the time, you probably feel pretty crappy. But I think we accentuate it even more with all of the medications, but we just feel so compelled to get them to eat, right? But it's, you don't have to eat for two, and your body was made to handle like this short time in our lives where we're not really that hungry and have these food aversions and stuff. Really, it's the hydration that is really the most important. And so when we treat these women in the emergency department, they come in and they feel terrible. When we give them a bag of saline, they feel like $1,000,000. They feel like they can go on again, And so the electrolytes are very important here. But yeah, you're right. I mean, it's an interesting point. That's why I like talking to non-medical people, because it helps me connect the dots of what is important where are these medicines doing to like their mental health but to their metabolism in general of what was really intended. That's very interesting.
Follow-up question. Is it valid to say, hey, if you don't feel like eating, don't eat. Just make sure you're drinking your salted lemon water.
Yes,
Is
it
it
is.
that simple?
It really is. I mean, we're not trying to tell women that they need to fast like for several days during their pregnancy, but if you don't feel like eating, it's okay. Your
And you're
body's not
not,
going to bring you down low, unless you're like a diabetic on insulin, right? Then we
right.
gotta kind of fix things a little bit. But outside of that, your body's never going to bring you down below what's normal, right?
Yeah, and I think it kind of ties into, the larger societal message, right? That somehow, if we don't eat for a day or two, like it's going to put your life in danger. And, it's kind of like Jack was saying, it's another example of where we sort of made something into a problem that's not a problem. It's just listen to your body's signals. And, you look at any other animal in nature and, generally when they're ill or there's something going on, they won't eat, right? And that's just normal and it's not really a problem, and it helps maybe promote some of our healing mechanisms.
Yes.
How along those same lines, how challenging do you find it to be, the introducing low carb during pregnancy, very much against the messaging? And like you said, the messaging is, oh, you got to eat for two, right?
Right.
So what kind of challenge does that add? And also maybe, what do you think normal is during pregnancy in terms of like how much weight should a woman gain during pregnancy, and what do we see today, in terms of average weight gain during pregnancy?
Yes. So to answer that question, about 75 to 80% of the patients that I treat, I have a pretty high risk population, but are already obese or overweight when I see them in their first trimester. And so once they're at that level, we recommend anywhere between a 15 or actually between a 5 to 15 pound weight gain for the entire pregnancy. And a lot of women can do that because as they start noticing and taking care of themselves, they start to lose weight and then the baby gains weight and then it kind of cancels out. So they end up, gaining, 10, 15 at the end, which is fine. But if someone were to come in with a normal weight, then the recommendation is about 25 pounds, maybe 30 at the most. I mean, in France, they only recommend 20 pounds. And so I think, in the United States, we give them a little bit of grace, but you don't really need to, gain a whole lot because the fetus already weighs like 7 to 8 pounds. The amniotic fluid that's around the baby, probably weighs another 7-ish pounds, and then the placenta, and then the extra fluid shifts that happen and the retention of fluids in the body is probably another, 5-ish pounds. So it's really not that much that's required in terms of weight gain. So what I tell folks to eat is, and it's hard because there's all kinds of different like ideologies right now about what is considered healthy, is particularly in the setting of a lot of vegetarians that I work with and stuff. And so I really just tell them, try to eat whole foods and only eat when you're hungry, and if you like meat, then try to be heavy on the meat if you can, because that has cholesterol, which is the building block for all your hormones. And, then when we start noticing that women are gaining a little bit too much weight or they become gestational diabetic, then I can have a more focused conversation about carbs and carb counting and carb ratios and things like that. But oftentimes women have this tremendous sense of guilt often of, oh, I need to drink milk for the baby, and I need to like eat for two and I need to keep eating even though I'm not hungry. And when you tell them like you actually don't have to drink milk and it's kind of like in the broccoli that you might want to eat, or like the calcium's in the broccoli that you might want to eat, or like in the meat, or you don't have to eat all kinds of meals all day long. There's a sense of relief that women have because there's this early satiety that happens where women, when they're pregnant, they eat a few bites and then they're full all of a sudden, and that has to do with not a lot of space like in your belly because of the growing fetus, but also just because the slowdown of the intestines that's really just trying to suck out every last nutrient and also just keep normal glycemia. It's, I try to really just ease off the pressures of what is a lot of women are feeling with pregnancy. But there's just so much carbs out there. I mean, women are like having all kinds of like protein shakes, and fruit, and fruit's another story, right? Because like women think fruit is like a free pass, but like fruit is fructose, right? And fructose isn't handled by insulin directly. Like your liver is the only thing that can break that down. And so then we get a lot of body inflammation and high insulin levels from that. And so it's a challenging one because when you have to tell women like, okay, you have to watch the fruit intake, they look at you like you're being mean. But, it really does, impact women. I mean, they just can eat fruit all day. And I'm like, you have to be careful, it's kind of addictive. And so, and it does cause a significant source of weight gain too.
And we never actually got to discuss earlier how you kind of came to low carb, how you sort of broke out of the kind of bubble and came to low carb yourself.
Yeah. So it's the gestational diabetes story where I started feeling a little bit confused about why we were telling women to eat carbs, but that was causing their glucose levels to go up. But my other story that I have is that I have something called endometriosis, which is like where the lining of the uterus will escape out of the uterus and implant into various places in the body. That has to do, very interestingly, with a gut microbiome disorder. And I'll get to that in a little bit. But that was around the time that I was working really hard at my old job and having a lot of stress, and like my intestines, and I was like super bloated all the time and having a lot of pelvic pain, and my periods were really heavy, and it just was I was just surviving. I was really just trying to survive. And it was also a time where I was having a hard time getting pregnant. And so what did I do? Like I went to my gynecologist to figure it out. And lo and behold, I have a 9 centimeter endometrioma, which is like a blood-filled cyst of endometriosis. And I did exactly what every good patient would do. I went to have surgery, and unfortunately my right ovary had to be removed. And every nice gynecologist tells their patient, in order to protect the other ovary so you don't lose that one later and go into early menopause, here's your birth control, right? But I was like, I don't want to be on birth control because I want to have more babies, and I want to try to figure this out. And so that's when I just did a deep dive in the literature. I started reading cardiovascular disease stuff. I started reading about, the actual mechanism of action, about what we know about endometriosis. I started reading the references to the textbooks from the gynecology textbooks, and really just started reading everything I could. And I was like, whoa, we're treating this all wrong. This is a gut microbiome disorder that has to do with all of the grains that I'm eating, that has to do with these diet sodas I'm drinking and the high sugar diet that I was on, and the stress that was damaging my intestinal microbiome and allowing leakage of inflammation and killing off all the healthy bacteria that was supposed to be there to help my immune system. And that actually causes leakage of inflammation down to the pelvis, into what we call the peritoneal cavity. And then your immune system's activated there to try to clear out all that debris. Then a woman has their menstrual cycle, and then the blood comes out vaginally, but it also comes out through the fallopian tubes. And so then those little blood implants from the lining of the uterus start to implant into the pelvis because of already the activated inflammatory factors there. And then they bleed and cause scarring just like any other area of the lining of the uterus, but outside. And so that's where I started getting really frustrated with typical OBGYN care, because it was so medicine based, and I was like, we know about all this mechanism of action stuff. Like, why aren't we kind of promoting this? But honestly, I just feel like, doctors are really tired and stressed out, and the OBGYN lifestyle is really tough, and so if we don't take a step back and really try to figure out what's going on, then a lot of times we can miss all of this stuff, and to my colleagues' credit, like they're really hardworking doctors. We do tough surgeries, and sometimes women really need like a hysterectomy because their uterus is trying to kill them. They're having their blood, bleeding to death and all this stuff. And so we need to help them with medicine and surgery, right? But I started noticing a lot of the discontent that my patients were feeling, because they were like, so it's just my hormones and you're going to give me birth control and surgery and that's going to fix my problems. And they were frustrated, and so was I. And so once I teach them all this stuff about inflammation and insulin, it like the light bulb goes off, right? And then women can really say, okay, I can do lifestyle, I can do medicines, or I can do surgery, and it's up to me, right? Because not everyone can do low carb, right? Like some folks have a lot of things going on, they can't meal plan. We really have to be in a position of privilege in order to do low carb lifestyle effectively. A lot of people are like have 3 jobs and a bunch of kids and all this stuff, and they just can't do it. And I understand, but that's just a season in their life. But maybe they need medicines and surgery for that short time, but they get to do low carb when they stop bleeding to death, but we just have to teach them how they got there, and then they get to decide how they want to proceed with treatment. And I think that's the essence of patient-doctor relationship and shared decision making.
I could listen to this for hours, and I want to ask all kinds of questions, but ladies, tell your friends about what Dr. Salcedo is saying. My God, save yourselves and your husbands and your boyfriends and your male partners the angst of having absolutely no idea what to do or what to tell you or how to help you. We want to help you. We want you to feel better. We want you to be happy and to be thriving. And we don't know. This lady seems to have some clues. Go, follow her, listen to her, find a doctor who believes what she believes, do what she says. I know I look a little crazy right now, but
Yeah.
holy cow.
It's awesome. I mean, what you're saying is what doctors believe too, Jack. It's like when patients go to their doctors or primary care doctors with bleeding issues and stuff, like a large majority of them will just send them off to the gynecologist because they don't really know how to deal with it. They think it's like a female hormone problem, and that's hormones, and I don't really know that, and it's really just as simple as what we're talking about. It takes a lot of investment to teach people this, but I talked about the physiology of PCOS in 5 minutes, that has so much bang for your buck,
Oh,
and
God,
then
yes.
once you teach people that, they can never forget it. And they're like, oh, okay, that sounds great, and then they get to decide. So it's not a female hormone problem, it's an insulin problem. And once we get that, it's whoa.
Yeah. So we talked about, gestational diabetes and pregnancy. We've talked about endometriosis, PCOS. We haven't really touched on infertility yet, but we've had Rob Kiltz on talking about that. I want to talk about one other significant area of gynecology, which is the gynecologic cancers. And what role do you think insulin and insulin resistance might play in those?
Yes. So the biggest gynecologic cancer out there is what we call endometrial cancer, type 1 endometrial cancer, which is uterine cancer. And it's the cancer that's most associated with modifiable risk factors. So obesity, diabetes, and that pre-diabetes, the abdominal obesity, all that. So that is kind of like the end stage of polycystic ovarian syndrome. Okay. So when a woman is not ovulating every month, then the lining of the uterus builds and builds. And then our excess fatty tissue also secretes a hormone called estrone, which is like an estrogen. And then that causes the lining to also grow as well. And then it just bleeds at random times. But all this excess estrogen molecule, it just allows that lining to grow and grow. And eventually it's going to turn into cancerous tissue. And so then those are the risk factors. That's the big concern about PCOS, hyperinsulinemia. I mean, I diagnosed like uterine cancer in a 38-year-old recently who was as thin as I am. And because she had 18 years of PCOS that nobody really like talked to her about. They were like, it's normal to have irregular periods, and when I really listened to her story, I was like, oh my gosh, like this has been ongoing for more than 10 to 15 years. And we haven't really done too much about it. And I just biopsied her. Like the guidelines would have told me not to biopsy her because she didn't have quote unquote the risk factors because she was 135 pounds and 5'5", and she had uterine cancer. And so it's unfortunate because, I think we think of periods for women as just like a female hormone problem again, but gynecologic cancers are a really huge risk factor when it comes to hyperinsulinemia and stuff. The other one is cervical cancer. because a lot of times, like, we require like a very robust immune system to fight off the human papillomavirus, and human papillomavirus is like the biggest reasons why women get cervical cancer. And so if we have an immune system that can't fight off the infection, then we get uterine cancer, I mean, cervical cancer, or abnormal pap smears that can lead to cervical cancer. And I see a huge population of women, in their 50s and 60s, where they start to get diabetes, they get hypertension, they're obese and stuff. And usually it's diabetes that will trigger this. And then they all of a sudden start having recurrences and reactivations of HPV, and they haven't had sex in 10 years, or maybe their husband's impotent and they haven't done anything, but they have a reawakening of the HPV that they had from a long time ago. And then that starts to wreak havoc on their cervix, and then they start to get cervical cancer. And so there's high correlations with metabolic dysregulation with uterine cancer as well as cervical cancer. So it's very important to highlight. So thank you for talking about that. No one really talks about the gynecologic cancers. So thank you.
Yeah, I mean, it's just amazing to kind of keep going down the list, and I mean, I'll say that oftentimes I'm focused on sort of the, top 10 causes of death, right? And there's nothing necessarily gynecologic on there. Maybe it sort of gets lost a little bit. We talk about how insulin resistance touches all of these organ systems. We go from heart disease to diabetes to lung disease to, even a lot of talk about psychiatric, the relationship between psychiatry and metabolic disease these days. And I think gynecology, maybe got a little bit lost in the conversation, but it sounds like the vast majority of gynecologic issues really are metabolic issues. And again, it's a opportunity to intervene early, right? Because if you take that young woman with PCOS and can, get the insulin resistance addressed, right, then she's not going to end up on my operating table, 40, 50 years later.
That's right. I know. I feel like my new tagline should be "Keep your uterus." Like yours is, stay off my operating table.
Yeah.
Keep your uterus. There's things that you can do to keep your uterus. And 1 in 3 women, by the time they're 60, will have their uterus removed. That's crazy. And most
How many?
of the stuff.
What's the percentage?
1 in 3. 1 in 3.
That's what I thought you said.
Yeah, 1 in 3.
Okay,
That's so crazy.
You've just addressed something that I'm actually an expert at, and that's marketing. And let me tell you, that's a great name.
Yeah.
Keep your uterus.
Keep your uterus. Yeah.
That'll catch attention.
Oh yeah, that's right.
I recommend it.
Right. Thank you. I know.
Yeah, this has been amazing. Maybe talk a little bit more about kind of what you're up to, what your practice is like, and how much this is becoming a factor in your practice. And then certainly people are going to want to know where they can connect with you as well.
Yeah, so my day job is, my academic practice at Loma Linda University Health in Southern California. But I've gotten so much interest in what I do, all over the state, but all over the country, that I do have an online telehealth practice where I see people in a telehealth capacity, and you can look it up online, consciousgynecology.com, and I usually see patients in Florida and in California. And so that's kind of ongoing. And I do a lot of educational consultations too for folks that really want my impression and some teaching about what's going on. And I have a big paper coming out in Menopause Journal in August, which is a really high impact journal that looks at hyperinsulinemia among women with abnormal uterine bleeding. And it's the first paper of its kind. And we proved that there is a huge association with hyperinsulinemia and abnormal bleeding as a whole, which is really exciting, because we're really trying to push the needle and change the narrative about what gynecologic disease really is. So that's coming out in August. I'll send it to you guys so you guys can have that and share it and stuff, and share it with doctors and things. And then I have a YouTube channel. It's pretty fledgling, but I talk about all this stuff too. And it's called Conscious Gynecologist. Yeah, so that's what's going on.
Love it.
Okay, I got to tell you, Phil, I had trepidation about this one. I really did, because I thought I got nothing to I got nothing to say, and I'm not even really that interested. And holy cow, th- amazing, fascinating stuff. Guys, any of you who live with women know how important this is. Women, any of you who live with guys know how big a deal this is to us. Follow Dr. Salcedo. Get in touch with Dr. Salcedo. We will make all the contact information available in the show notes. This is big stuff. This is really significant. One of the best we've done. And I had an hour ago, I had no idea I'd be saying that. So thank you.
Thank you, Jack. Thank you.
All right. This has been Stay Off My Operating Table with Dr. Philip Ovadia. Our guest has been Dr. Andrea Salcedo of Keep Your Uterus fame. And we'll talk to y'all. We'll talk to y'all next time.
Thanks.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.